Welcome back, everyone, to the second episode of season 2 of Fresh Air. And so we're continuing on our categories of some high yield cases for trainees who are just getting back into pulmonary pathology. So take it away, Rennie.
Okay, so we have 5 more cases on tumors, and I'll read a bit of the history. This is a woman who is 70 years old and has a condensation in lower left lobe that doesn't disappear. So they do a biopsy, and I would ask you, who wants to describe or look at this biopsy?
I can do the first one here. So it looks like we have some needle core biopsies here. And then we have a lesion here.
I'll travel you through the biopsy, and then I'll go higher magnification.
So it's quite inflamed. There's some pneumocytes there, but it seems more like a spectrum to me. I find a really helpful feature is comparing to see if there's an edge of it or not. Whereas this looks more continuous. There is some atypia, but I think these cells are kind of respecting one another. So I don't think anything here I would call a tumor yet. So it's a consolidation. So, but I don't know if there's some cilia there. Looks a little bit fuzzy.
Yes, I think these are
cilia there.
Cilia
Yeah.
or fast.
But if it is real cilia, then it's a reassuring feature. Then we got some alveolar macrophages that have some pigment in them.
All the biopsy is the same. What do you think about it?
So I don't. There's nothing here I would call malignant. I think I would. I think I'd be descriptive in this, and I'd correlate with the radiology of what was going on. So it's a consolidation process, right? So there appears to be a little bit of thickening of the septa here, and a lot of inflammation, and there's some macrophages. So then I'd take a step back and make sure there's nothing else. So I always make sure there's nothing in the interstitium there that's kind of infiltrating through, because sometimes these things where the interstitium is just expanded. So take a close look. This pigment doesn't look like melanin to me, but I always keep in the back of my mind that there's not a sneaky melanoma sneaking through there. But I think you've already tricked us on the melanoma, so I think I may be safe from that. and then maybe are you trying to highlight some? The other thing you always think of too with all the smoking changes is whether it's Langerhans cells, but I haven't seen any definite ones. But you probably have a low index for throwing a CD1A on this. But it doesn't look that like the typical stellate scar to me, at least in its core, but these things can be tricky on core needles. I don't know, team, is there anything else that I'm missing here, or you do on this?
No, nothing. It's okay. Everything is the same. So the diagnosis would be, for me, also, it was reactive inflammation, and it has all the things that you said. The cells respect each other and are not clearly atypical, and there is a lot of inflammation, and there are macrophages. I don't know if any of you want to add anything else that makes it reactive.
No, I think this is all correct. Exactly like you guys said. A very cytologically bland, low cuboidal cells with no nuclear atypia whatsoever, respecting each other, not crowding with each other. Cilia are present here and there. And the background is fibrosis and inflammation. There's alveolar macrophages. My question really to all of you actually is, so what is the point here of looking at the clinical finding? Let's say I tell you this is a 15 centimeter PET positive mass, highly suspicious for malignancy. Does that change the pathology?
It doesn't, but I usually will add a comment saying that, that I can't exclude perilesional sampling, and that they should make sure that this is concordant with the lesion, right? Because that to me is a discordance, right? If it's a 15 centimeter PET positive lesion,
right?
This wouldn't really explain this.
True.
Yeah,
again,
oh,
my point is, I do agree with all the description made and discussed. Again, consolidation or clinical findings does help us most of the times, but would not be the main thing which I'll be based on. I'll be basing on what I'm seeing under microscope, and adding other stuff as a toppings on a pizza kind of a thing. But the base, the dough on the base, that's what is microscopy. Again, the point here is this: the spaces appear to be, the alveolar spaces appear to be all in irregular shapes and sizes, and the interstitium is expanded with inflammation. So if consolidation, I'd be thinking some flavor of acute lung injury. It could be, if I see island membranes and airspace fibrin, then DAD kind of situation, otherwise organizing acute lung injury situation. But especially those glands where they become smaller and round, that's when I'll be thinking if it is kind of a alveolar spaces entrapped in the background acute lung injury, or what exactly is going on there. And also I've tried to see if I can make an look for some microscopic findings where I can find the etiology. In this case, there's interstitial inflammation, and also this the glands around the small blood vessels right here. Can it be peribronchial metaplasia? So can it be some kind of chronic small airway injury or fibrosis in between? Are we dealing with the interstitial lung disease? What's Are there any consolidation, means reticulations in addition to the consolidation in the imaging? Is this a lower lobe predominant process, upper lobe predominant process? So again, all those findings could give me some idea about what reactive situation, or is it a part of a bigger process like interstitial lung disease going on in this biopsy?
Yeah, I agree with that, Raghav. One thing I'll mention is that I also thought about ILD actually. I was thinking, is there just a fibrosing ILD and they've missed the main mass or whatever? But it's good for students to know at least that a needle biopsy is never the initial biopsy for a ILD case. So they're almost certainly going for a mass when they do a needle biopsy, core needle biopsy. So if you see and you can see an ILD, of course, because you can miss the lesion, or an ILD can be in the background of a mass, but an ILD will never be an appropriate explanation for a core needle biopsy, because a core needle biopsy is always going for a mass lesion. That's worth pointing out, I think.
it's not usual to find an ILD when they are looking for a mass. Not could
Not
happen,
usually,
but
but
it's
you
not.
can. I mean, I've seen that. They miss the mass and they hit fibrosis and honeycombing in the background. It happens sometimes. Or they go for a mass lesion and you hit, for example, sarcoid, which is also an ILD and a mass lesion. Sometimes that happens.
Well, yeah.
But not common. I agree. Not common to find an ILD like that. One thing that I was thinking about as you kept showing that thick artery, I was thinking, if the clinical is that like of a sequestration, this would be a good fit for that. But it's unlikely. It's unlikely that that's the answer, unless it's a great fit from the clinical point of view. But the point I was making, Matt, is that for me this is benign no matter what the clinical setting is. So the pizza, I love that pizza analogy. So for me, the base of the pizza is always the same, no matter how many toppings you add from reading the imaging and the clinical setting.
Yeah, I had a question. So now your favorite resident has ordered TTF1 and P40 on this, thinking that it's an adenocarcinoma.
Yeah.
So now how do you interpret? Because the TTF1 is positive in all these pneumocystes lining these alveolar spaces. And now P40, I would say it's negative in those pneumocystes, but it's positive in the basal cells. And now your resident would come to you saying that both TTF1 and P40 is positive in this needle core biopsy where it looks like adenocarcinoma, but I'm not able to explain this P40 positivity. So then how would you tell them, or how do you guide them?
You yell at
That's
them
why,
and then
why
you throw them out of your office. No, you don't. You don't, you don't do that.
at least they have to know about basal cells. I don't think they make that often, this mistake. I use this biopsy for that, to say, because they have this tendency to order TTF1. and to prove that it's an adenocarcinoma and it's from lung. And here the TTF1 would be positive in all the cells. And you have to look at the cells, everything. TTF1 won't give you the answer. I mean, I think the important lesson is in looking at the cells and the architecture and looking at these things that they are separate, that are not clearly malignant. I say hobnail, that these are hobnail, finely vacuolated, that you find the macrophages, foamy macrophages, and these are the lessons they have to learn from this biopsy.
Yeah. There's no shortcut to learning H&E. There's absolutely no way to avoid that. No matter how much you try, there's no way to avoid H&E.
So we move to the case 7, and I asked Raghav if he can.
Yeah, absolutely.
Look
Yeah, I
at
was
this.
going to volunteer to make this one.
He volunteered you.
Yeah, thank you for volunteering
This
me.
one has no history. It's a mess.
Oh, that's great. I can create my own history, you know. It's a beautiful core biopsy. You got some normal ovulated lung parenchyma, and then there is some areas of necrosis, and then there is dark blue, small blue round cells. So you got everything on the plate, all like carbohydrates, proteins, and lipids, everything on the plate. Again, I'm going back to the food. I don't know why I'm going back to the food this morning, even though I had my breakfast. So lots of necrosis, yes, lots of necrosis, but these cells have this perfect, like this nesting or whatever, this peripheral palisading of this large cells. They've got neuroendocrine appearance in the sense that they look very, what do you say, neuroendocrine appearance. The reason why I said that, because of the growth pattern. It is nested and it's peripheral. It's got the peripheral palisading appearance. That's the neuroendocrine growth pattern for me. I've not yet commented on the salt and pepper chromatin because here many of these cells has got prominent nucleoli and it's got some vesicular chromatin and there's frequent mitosis also seen, not as frequent as I expect to see in a small cell. And the most important thing is, in addition to that neuroendocrine growth pattern, I also have this abundance of, not abundance, like moderate amounts of cytoplasm. So I'm absolutely away from small cell. I am into the large cell neuroendocrine carcinoma territory. But I want to see the entire biopsy before jumping on to that direction. Because I don't want to miss an additional component of small cell, or I don't want to miss or interpret this as large cell neuroendocrine. In fact, it would turn out to be a non-small cell, kind of a squamous cell, poorly differentiated basiloid type of squamous cell carcinoma. So I want to look around to make sure I'm not seeing any other features or anything. But at this point of time, I think it looks one tumor here, and it has this pattern, and I'm thinking large cell neuroendocrine carcinoma. Again, in the core biopsy, since it's a diagnosis and resection, I would say and large cell neuroendocrine features in the comment. Top line again, you can, if you say non-small cell, they will be thinking adenocarcinoma or squamous cell carcinoma. So again, we can say poorly differentiated carcinoma. Again, yeah, those top line can be, I don't know how, I'm curious to hear how Sanjay and Matt would top line this. Would they do like large cell neuroendocrine carcinoma because we have not seen the resection? It's a core biopsy, or would you say non-small cell carcinoma with suggestion of large cell neuroendocrine carcinoma features?
Matt, you want to go first?
Assuming the P40 is negative on this, like I would do stains definitely before it. But if P40 was negative and neuroendocrine markers were positive, then I think I would call it a large cell neuroendocrine carcinoma. I think that there's enough here for me to call. But I think it's fine either way. Oh, okay. Well, do you have something to say?
I have other stains. I have other stains.
Okay, see, the one trick I think that she might have up her sleeve is this could be a met from somewhere, and then the whole discussion is moot. It doesn't it doesn't matter, right?
No, there is no trick. I did this a large mass in the lung, I guess, and and there is no way to tell in a high grade neuroendocrine if it's from the lung or not.
Right.
As we know, this is chromogranin, very positive. Would you say I would call it non-small cell lung cancer, not always specified, dot, it could be a large, oh no, non-small cell lung cancer with neuroendocrine features, sorry. This could be a large cell neuroendocrine. This is what would be my diagnosis. But this diagnosis needs immunohistochemistry, doesn't it? Or
Yes.
would you call it anyway? Without,
No.
if it's not neuroendocrine positive, you won't call it. So
Correct.
this is chromogranin.
And I think that's what also Raghav was implying, that he needs the immunohistochemistry first and then would call it, whatever.
Correct. Correct. Yeah, I would definitely do immunohistochemistry to prove the point that it's neuroendocrine. And also, I would also get a TTF1 and P40 to exclude that squamous cell carcinoma. But also look at the history if I'm looking at something metastatic or something coming from somewhere else. But if it's a metastatic tumor, yeah, of course, like Sanjay mentioned, all our discussion, whatever I told would be like.
Yeah. I mean, you could say that this patient has a GYN primary and you knew that before.
Yes.
And then Paxate is positive, and that completely changes the discussion.
Exactly.
But to Raghav, to your question, which is a very, very good question, which is how to frame it on the final diagnosis, right? If you look at the WHO for guidance, the same book you showed in the beginning, it actually has says two different things. One is it says there is a descriptive way that they give to diagnose it, which is something like non-small cell carcinoma with neuroendocrine differentiation of features. But it also says that you can diagnose large cell neuroendocrine on small biopsies, especially if you have abundant tissue, like in a core needle biopsy. So this would be the right setting. And no matter what you do with this case, it could still turn out to be wrong if you resect it and you have a small cell component mixed in with that. So let's say this thing gets resected, and in the resection, 50% of it is small cell and 50% is large cell neuroendocrine. It could still be not wrong, but it would be a combined small cell carcinoma. So I feel that no matter what rule you set for whether you can diagnose this or not, it's still very tricky, because it's still possible that this thing will be mixed in with a small cell component on resection. So I think it's open. Anybody can do what they want with this. I think both are acceptable, either to describe or to call it large cell neuroendocrine on the biopsy. Thoughts, guys?
I don't really. What does it say, brother? Large cell carcinoma. Sorry.
This is what they had in 1967.
Clear cell carcinoma.
Wow.
Giant cell carcinoma.
I guess, Sanjay, one question I have is, does it matter at all whether it's large cell or small cell or combined in a way, right? Like in terms of, I know there's different prognoses, right?
Yes.
But they often treat them similar, right? Maybe they'd be more likely to resect if it was a large cell. But if it ends up being combined, does it really matter?
I don't think so. I think what will happen is that if this lesion is resectable, it will get resected, no matter what you call it, right? Even if you call it small cell and it's resectable, it will get resected. If this lesion is not resectable, let's say it's widely metastatic, there it might be make a difference, because if your oncologist treats large cell neuroendocrine like small cell, there's no difference. But if your oncologist treats a large cell neuroendocrine like a non-small cell carcinoma, then it's very different, right? The treatment is very different. Yeah. You might still say there's no difference because they're both going to behave in a bad way. If it's metastatic large cell neuroendocrine versus metastatic small cell, it makes no difference how you treat, because both are going to behave badly in the long run.
Yeah.
But I think there might be that difference depending on how your oncologist treats a large cell neuroendocrine.
Large cell are a weird group because some look like a small cell molecularly, some look like small cells, some look like adenocarcinomas, and are a weird group. I don't see the point why you are allowed to say squamous cell carcinoma in a small needle biopsy, and you are not allowed to say large cell or pleomorphic. Because if you say squamous cell carcinoma, if they get the resection and there is an adenocarcinoma component, you made a mistake and it's an adenoscamose. Then why are we allowed to say that but not? But I don't see the point in not allowing us to say it, because it's obvious that we have a small part and we can make a mistake.
Yes.
When we get
That's a great point. And actually, yeah, I totally agree with you, Irene. It makes no sense to not allow people to diagnose what they see on the small biopsy. And I frankly, I don't think it's even a mistake. It's not a mistake. It's just sampling. You have correctly diagnosed what was sampled. And then when you resected, something else came out, which is expected.
It's not what the patient has.
Yeah.
It's not what the patient has. The patient has an adenoscamose, but you couldn't see it because you only saw this.
Correct.
Yeah, the part of the reason why I think I call it large cell neuroendocrine is just to make sure that they realize that clinically, right? And that if it's not resectable, then they use the neuroendocrine chemotherapy if they think that that's what's warranted, right?
Yeah, don't know how, it really depends on what they do for large cell neuroendocrine on the oncology level. And I think there's some variability there because there is really no accepted effective therapy for large cell neuroendocrine. People do whatever they want to do.
Is it TTF1?
No, this is
K67. K67.
Yes, and the TTF1 was this one.
Okay.
No, sorry, this is INSM. How do you say?
INSM1.
INSM1. Yeah.
INSM. It's also horrible. I say INSM. This is this one, and I think I showed TTF1 also. Is this one? It's also positive.
Yes, it also makes me mad when people say SRIF for SRIF, but I've learned to take a deep breath and let it go. I'm like, fine, call it whatever you want.
Residents love it. It's like straight. They love it. Keratin here, pankeratin.
Yeah. Is this the same case, Irene?
Yes.
Same case?
Same case.
Wow. Yeah, I don't think that the exclusion of small cell is that easy in this case. It maybe I agree it looks like non-small cell at first glance, but I think it's tough. Some areas can be interpreted as small cell by some people at least.
Yes.
I think for me the nucleoli push me away, right?
Correct. But do all the nuclei have nucleoli? So Irene, can we see it high mag again? So just leave it on any one field. So here I would say on the left-hand side, just leave it there, Irene, on the high mag. Almost none of the cells have nucleoli. Agreed? Do you agree?
I agree.
Almost all the cells show nuclear molding. Almost all.
Yes.
Correct? And the cytoplasm is abundant only in a minority of cells, not the majority of cells. So even here, you could make a case that this is combined small cell carcinoma. It's not that easy, I don't think.
Yeah, I think the cut's a little bit thick though too. But
I don't see it. I see a lot of red cytoplasm, red, or I don't know how to say that color in most of the cells. Here or there is cytoplasm. I struggle with some biopsies, but in this case, I think was clear large cell. I don't have the blue impression, that blue. Well, here you are absolutely right, but I think it's a problem of fixation.
Yeah, but this is a little tricky, right, Irene? So when you see the cytoplasm, then the fixation is fine. But where you don't see the cytoplasm, then there's a problem with fixation. That's a little bit of a tricky argument to use.
Yes.
Right? People also use that for crushed biopsies. So they say here it's a large cell phenotype. This is fine. There, where it looks like small cell, it's crushed. So I don't know what that is.
Yeah, it's the analogy of sour grapes.
Yeah, that's like a double standard reasoning.
It's a it's a mess. It's a
It's a
problem
mess.
actually. And you see a small cell carcinoma, and then you see a group of cells that have nucleoli.
Correct.
And you say, oh, should I say that there is a component and causing me trouble because I'm going to be called, are you sure about this component? No, I'm not sure.
But I don't see that as a
But
problem, Irene. So if you have a clear-cut small cell carcinoma and you have admixed anything, squamous, adeno, non-small cell NOS, large cell neuroendocrine, it makes no difference, right? They are all treated the same. So I don't worry
it's
much about what is admixed with a small cell. I'm worried more about, is there any small cell that I can
if
call?
you work in
Yeah.
a place where it's not that easy to put, oncologists don't like very much this combined category. It's not easy to put them. The guidelines are not that clear for combined, I think.
I see. For ours, we diagnose it all the time, combined small cell, and our oncologists treat it like small cell. So it might be also institution to institution, difference in how people approach it.
Finally, I put the napsin because I used napsin in many settings. It has helped me sometimes. And it helps me in this. I know it can be positive in large cell neuroendocrine, but in my hands, well, here there is a cell. In my hands, I've seen also combine adenocarcinoma with large cell neuroendocrine, and you see how the adenocarcinoma stains napsin and the neuroendocrine don't, and I like it.
Yeah.
When there is the doubt between adenocarcinoma or large cell neuroendocrine, that is not in this case.
Can I ask you guys a question?
Yeah.
So let me just, for this small cell, large cell thing, right? So everybody agrees that if you have virtually no cytoplasm, that is small cell, right? Everybody agree? If you have almost no cytoplasm and lots of molding, that's small cell?
As long as they don't have nucleoli.
Yeah, no nucleoli, right? And let's say no nucleoli, no cytoplasm, or very little, and molding, and all the classic neuroendocrine markers like you showed here, that's a small cell, right?
Yeah.
And then you get a little bit more cytoplasm, but no nucleoli. Is that still okay? Is a little, or it not okay to be small cell?
Well, I guess it depends on the other features too, right? Is there molding? Is there?
Yeah, everything else is there, but you have a little bit more cytoplasm.
I think so.
It's okay.
Because often you see that in resections when you see them.
Yes. How about then you have a little bit more cytoplasm, and then you have very small nucleoli in one or two cells. Is that still small cell or large cell neuron?
Yeah, then I'll take a voting. Like I'll show it to 5 people, and then 2 people say small cell, 2 people say large cell.
Exactly.
And now I'm stuck with what to call, and I come back to my office confused. Where did I start, and now where am I going? And then there's a lot of question marks. That's what would happen.
So
with
Raghav,
this
let me ask you this question. Does it make sense to you that a tumor that has exactly the same immunohistochemical profile as a small cell is called a completely different thing just because the cytoplasm was slightly more and the nucleoli were slightly bigger? Now it's a completely different entity. It needs a different treatment, different prognosis, different name, different chapter in the WHO book. Just because the cytoplasm was slightly more and the nucleoli were slightly bigger, everything changes about that entity, which was otherwise identical to small cell. Does that make sense conceptually to you?
It does not, because if they say that we have to look at the nuclei, but suddenly the cytoplasm becomes the important factor.
Yes.
And again, yeah, we have gone through that road too many times, and exactly we don't know the right answer for that,
Yeah, how
unfortunately.
about Matt and Irene? So does that concept make sense to you? That a little bit slightly larger cell suddenly now changes everything for a tumor that otherwise is identical to small cell?
No.
Ultimately, they're
comfortable
both
with
high-grade
cytoplasm.
neuroendocrine. Yeah, and they're ultimately both high-grade neuroendocrine carcinomas, right? And
Yeah.
you
So the
know,
point
in
I'm trying
some,
to make is, why do we separate them when they're identical? And the only thing that's different is cell size is slightly larger because the cytoplasm is slightly more, and a few cells become to have nucleoli. Is that enough of a difference to justify a completely different entity? That's really the point I'm bringing up.
I think the justification is there's different clinical pathological features, right? Is that I think they do slightly better than a small cell, right?
I don't think so. So if you look at metastatic large cell neuroendocrine carcinoma, it has the same bad prognosis as small cell. And if you see a stage 1 large cell neuroendocrine carcinoma, it has the same prognosis as a stage 1 small cell.
Yeah, it's probably partly too because things get lumped into the large cell neuroendocrine that maybe aren't that, right?
Yes, exactly. The problem is that you are also lumping some adenocarcinomas into the large cell neuroendocrine category. So it's a really bad entity because it's lumping 3 things together, all of which are different. It's lumping, just like Irene said, it lumps small cell and carcinoids and adenocarcinomas, all 3 into one group because of various criteria that they've come up with. But I feel it doesn't make sense in a case like this, like she showed, which is classic high-grade neuroendocrine carcinoma, that to call it large cell neuroendocrine, and I agree that we are forced to call it that, and it's fine. But I don't think it makes sense conceptually that this is anything different than a small cell.
The problem is we cannot separate in this group, in this mixed box, we cannot separate by morphology the ones that molecularly look like an adenocarcinoma or that, because if we could, they would have said that it's not that the ones that you are more in doubt are a small cell and the ones that look much more like an adenocarcinoma have an ALK.
Right.
It's a problem to separate this.
Correct, but molecularly they can be separated, right? So you do have a subset that is positive, not just for napsin, but also for KRAS. So they have both the molecular and the immunohistochemical features of an adenocarcinoma. So they could have separated that and said, look, those are not large cell, those are actually adenocarcinomas with neuroendocrine features. But they said, no, we'll still keep it as large cell neuroendocrine, call it adenocarcinoma. Like also by RB loss and TP53 mutations, there is a subset that is identical to small cell carcinoma molecularly. And they could have said, let's just call it small cell and remove it from this group. But they said, no, this is large cell neuroendocrine carcinoma, small cell type.
Yeah.
It would make us have RB. Everybody should have RB to classify. I think we are not soft tissue yet. And I think we are allowing everybody, or they are allowing everybody to diagnose or saying, as everybody doesn't have RB, cannot perform RB, so we still have this entity like this, just in morphology.
Do you guys ever use RB for these?
I have not, and the reason I don't is because RB loss can also be seen in large cell neuroendocrine, which is the same as small cell in my mind. But, as long as you have these two categories existing, the RB is not going to help you because it can also be lost in large cell neuroendocrine carcinoma.
I think what people say is it helps you say it's neuroendocrine versus an adenocarcinoma because it's less commonly lost in high-grade adenocarcinomas than it is in neuroendocrine. So if you have something that you're on the fence on, is you can use RB as a way to push you. I think this is how some people will use it.
That's a good argument. Yeah, I see the point there. Do you guys use it, Irene, Raghav?
No, we don't use RB. Yeah.
Yeah.
We just if we have a question or anything like you said, Sanjay, we just sign it out as high-grade neuroendocrine carcinoma. When we are not able to decide, even after showing to different people, and then do molecular testing to see what kind of mutations are there, and then at the back end try to give them some idea about what kind of therapies or something like that. But otherwise, we have not yet gotten into the RB1 kind of situation.
Yeah. The problem with molecular for RB is that you're going to miss a lot of the mutations because a lot of mutations aren't just missense mutations or nonsense. They can be like large deletions, which aren't picked up well by NGS.
Yeah.
So in some ways, the IHC is actually better because it assesses whether the protein product is being expressed.
Is it easy to read, Matt? Do you use it?
I do, yeah. It's kind of like P53, right? But it's a null pattern that you're looking for, right? And so the normal staining is kind of a patchy staining throughout the tumor. And then the loss is basically no expression. It's pretty clear.
Do you also have a strong diffuse that is abnormal like you have for P53, or that in RB you don't have that?
Not that I've seen. I'd have to check the literature to see whether that's in there as well. But most times when I see it's abnormal, it's completely lost.
Very interesting. I'm sure it's coming down the pike where we will use it eventually.
I
Yeah,
think the GI world.
what kind of controls would you use for RB then? Any normal tissue, any tissue which shows normal expression?
Yeah, it's expressed patchy in almost every tissue. And so it just, I guess if you want an on-site control that also shows loss, you use a small cell or something.
Yeah, okay.
Yeah, this is a great case for all the discussion we had here. This is just a great case to spring that off. So thank you, Irene.
So we move to case 8. This is for Sanjay.
All right. I have to redeem myself after my melanoma disaster. Right.
This is a woman that is transplanted. She got a transplant and now has a nodule in the lymph. They get a biopsy.
All right, so lots of necrosis going on. Oh, bugs.
I didn't want to get that close.
All right.
A lot of necrosis.
You've made me happy already.
You saw it from there.
So the first thing that I tell residents, don't jump to stains before looking at the H&E, right? Especially on a case like this, where you already have a transplant history, where the pretest probability of infection is super high. At least look to see if you can see the bugs on necrosis. So clearly here, there's necrotic debris and bugs in there. They're round. But I'm having trouble saying what exactly the bug is in this necrotic debris. Can we see a little bit more of it? Because I'm trying to, is it yeast or is it hyphae? So far, they're all round, but I'm trying to get a sense. They look big to me, at least on the screen. They have some kind of budding, at least some of them do, I think. Let's move it around. Yeah. Do we have some granulomatous rim where we can see it in the histiocytes or anything? No, it's all necrosis.
Only necrosis and these holes.
Okay, so you know what I really want to make sure is that this is fungus first, which it looks like. I want to, my suspicion is really for Cryptococcus. This is the right setting. They're a little bit big, but I think that's the best guess here. Some are really big, some are a little smaller. I think I saw some narrow base buds. So on the right-hand side where you're showing histiocytes, see, I think that's much easier to tell now, size, because you have some sort of a comparator.
So there is a here,
yes,
this must be a granuloma.
Yeah, I like it there. And here I think it is much better for Cryptococcus. I can see some smaller forms. There's a halo around them. I think that Cryptococcus is my top thought here. So I would want a GMS and a musicarmine. I really don't have much of a differential at this point. On the H&E, Cryptococcus is really my top thought. But the pleomorphism is much easier to see on the GMS than it is on the H&E, although you can see it on the H&E too. So let's see. Lots of bugs, as you would expect. Now you can see that, yeah.
In biopsies, the yeasts look bigger and are inflated. The microbiologist always tells me that things are not that easy to see in biopsies for her.
Yeah, no, yeah, you're right. I mean, I thought it was really big in the necrosis, at least. I think that's when you get to the histiocytic rim, you get a little bit more sense of size because you can see adjacent something, you have some reference nuclei and all that. But I think so clearly GMS positive and lots of pleomorphism. So far I'm still with crypto. I see some more.
I don't have a musicarmine. I have a pass. I think it's better than this.
The other thing that biases me a little bit is you're in Spain and you're unlikely to have other things. You could, but it's unlikely to be other things there, like cocci and all that stuff. So I'm cheating a little bit.
Absolutely right. I don't see fungus very easily, and
beautiful.
I know I don't see very often fungus, and this is a crypto. And
So this is
this is the
PAS
one I can.
positive,
This
right?
is the one I can have.
Yeah,
This is the one everybody can have. The crypto.
correct. So what is this, just PS alone, Irene, or ABPS?
Yes, I think it's PS.
PS
PAS.
alone. Because you can do an Alcian blue PAS combination, right? ABPS. And I think I can't remember now that maybe the Alcian blue also stains the Cryptococcus capsule.
I think I don't have it scanned, but I think I did it because I didn't have Carmine, but I read about this Alcian blue and I did it in this case and it was positive. You are
That's great. So was it culture confirmed?
yes, and the treating clinicians were really happy. That, but we're really surprised because the image looked like a cancer, but they were really happy.
Yes.
That they could treat. So
One of the, I think one of the biggest uses of a pathologist is to get a bug diagnosis when they're expecting cancer. I think that's one of the biggest contributions from a pathologist to diagnosis.
Can I ask a
I'm
question?
so
about this
happy
one?
to have it also.
So
Sorry?
it looks like there's like big areas of infarct here, right? I guess it's like, I guess the one question I have is chicken or egg. Like, was there an infarction that got colonized by Cryptococcus, or did the Cryptococcus cause that?
No idea.
Right. I guess there's a little bit of a granulomous rim to it, which suggests that it's all
It's a
causation.
necrotizing granuloma. Yeah.
Yeah.
But I think
I've
that
just
can
seen.
happen sometimes, Matt. I think that you
Yeah.
can get infarct-like necrosis
Yeah.
in organism, even in histo, and the chicken and egg thing is unresolvable. It's just impossible to be sure.
There's so many of them. It's crazy.
Yeah.
Yeah.
There are occasional narrow base buds. You can see them here and there, where there's a bigger one and then a smaller one off of it. Yeah, like that. Yeah. Beautiful case.
And is the what I thought the only microorganism or one of the few microorganisms that you can see in the H&E for comparison. You don't see it
Well,
clearly, like holes in the tissue. Not the only, but
yeah. Actually, the only one you cannot see on H&E is
Histoplasma.
histo. Yeah.
Yeah.
And that's
You can,
only in the
yeah,
necrotizing granulomas. The rest you can all see. So crypto,
yeah.
blasto, cocci, aspergillus, and of course the mycobacteria you can't see. But of the fungus, histo is the only one that you cannot see on H&E.
Yeah, when the cocci, the big, the sporangia, they open up and release that small little endospores. Those sizes would be very similar to sometimes like this one where the crypto has got variable size. So if they're on the smaller side, and if you don't look at the entire slide and then you jump onto making a conclusion, then you might get confused there. Otherwise, like Sanjay mentioned, once you have the variable sized and then you have this halo around the yeast forms, I think that gives it away, especially on the H&E. I feel it's very helpful to notice that point.
Yeah. Can I ask you guys one question? So let me give you a hypothetical, okay? Hypothetically, let's say instead of the PS, Irene had done the musicarmin and it was positive, okay? So in this case, how would you top line the diagnosis? Raghav, we'll start with you and then I'll go around. How would you top line the diagnosis?
Yeah, in this case, obviously, I would say if I can't make out the difference, I'll just say fungal infection, leave it for cultures. But if the musicarmin is positive, again, I would say it's favor cryptococcus.
And favor meaning that you still have something in your differential.
Yeah, there's something in the differential. Not really, because not really. So I can remove the word favor and just put cryptococcus. The only thing pulling me back is that microbiology cultures.
Yeah.
We don't know how much of tissues they submitted, or they they give some tissue to you, but they submit most of the tissue to other place. If that kind of a situation happens.
Yeah. So you're worried, Raghav, just to understand what you're saying.
Yeah.
You're worried that the
Yeah.
microbiology will come back some different organism.
Yes.
Has that ever
yes.
happened? That it looks like this, and stains with mucicarmine,
No.
and the microbiology came back a different?
No, because we have a good system here that the microbiologist would check back with the histopathology people, and we look at the slide together
Yeah.
and we discuss what's growing in their culture and then what we have on the slide. So as long as you have the communication, I feel strong enough for my whatever diagnosis I give. But say, for example, if you're in a situation or a institution or a place where you don't talk to the microbiologist, then
Yeah.
I feel you have to use some in between hedging words, saying favor, suggestive kind of a thing. Otherwise, in this situation, I clear cut Cryptococcus.
Yeah. Matt, what would you do? So,
Yeah.
mucicarmine positive and this morphology, how would you top line it?
I often use a term like morphologically consistent with, and because I'm basing on morphology, and that takes into account that sometimes there's things that look like this, but with more advanced culture or genetic techniques, they can further classify it. And I'm just saying based on my morphology.
So same question to you, Matt. So have you seen a case that looks like this and stains with mucicarmine that ever turned out to be something other than Cryptococcus?
No, but I don't have as great of communication as with the microbiology colleagues looking at cases and comparing. So it's
I see.
working a little bit more of a silo.
Yeah. Irene, how about you? How did you top line this case?
I say something like a necrotic tissue with granulomas and yeasts. And in a comment, I said the yeasts are morphologically consistent with Cryptococcus. The differential diagnosis is with histoplasma, but it's not looked in the. And I make a short differential saying why I think it's a Cryptococcus. And I bottom line that they should correlate with microbiology, or that microbiology can say something else. The problem is in these cases, there is no normally a culture because they suspected lung cancer, and they send this tissue only for
Correct.
me.
Yeah.
So I haven't had we only had a bad correlation, or we only have a bad correlation when I see very few microorganisms and they don't see it, then I still doubt that if something is. I saw it, but the clinicians, as they were expecting cancer, they want microbiology to say that there is a culture that they can treat it with this or with that.
Yeah.
So I have to say it like that.
I see. Okay.
Because in times when if I say is this, they anyway say, oh, this is so surprising. We need to talk to microbiology anyway.
Yeah. So I mean,
I
what I don't understand is you cannot have a more classic case than a Cryptococcus case, right? I mean, I know there are cases like histo, for example, doesn't have a confirmatory stain, and blasto and cocci can be similar, and there are many situations where you can't be sure. But in crypto, if it looks like crypto, it's in the right setting for a crypto, and you have a confirmatory stain, mucicarmine, it cannot be anything else. But yet we are, we often hedge it. I mean, all three of you have basically said the same thing, is that you leave some wiggle room. And I feel like we are maybe too conservative, where something is clear cut, is clearly Cryptococcus like that, that's just my thought. And maybe I feel like that because I've been, this is just my passion and this is what I like to do. But I do recognize that most pathologists actually do it like the way you three of you described. They hedge it a little bit, either in the diagnosis or in the comment.
Do you just say Cryptococcus?
Yeah, so for this, I would say necrotizing granuloma, parentheses, Cryptococcus is present. So let's say, so now let me bring up all the issues. I've never seen a culture positive that was discrepant in a case like this. And I have many Cryptococcus in my life, never happened. Second, if the culture is not positive, it's not positive. It's not always positive in bugs. And we know that from many studies that I have published, that the culture is not always positive. In fact, in histo, most cases are not positive. The vast majority are not positive. And then, if you have really have a bug where you cannot be sure, then you hedge it. But I think crypto is the the classic case where you can be sure, and you do have a stain where it can bring you to like 99.9% sure. So I don't see any point to hedge it. That's why I call it flat out.
Well, maybe I'll jump
The
on that
time it
bandwagon.
takes, the time it
Okay,
takes to
okay.
have the culture.
Yeah, okay, Sanjay. Yeah, that was great. And so, yeah, for the next cases, yeah, no hedging. That thing is like, yeah, no hedging anymore on this mucocarbon positive cryptococcus.
All right, great case, Irene. Great case.
Next case is number 9. I guess it's for Matt again. This has a little history. It's a woman, never a smoker, and it's a frozen section. We
Oh
haven't
my
seen
God, you
any.
already gave it away, Irene, with that history.
See. So we have some cystic changes and some hemorrhage. And then so these cystic spaces, hemorrhage, and then we have these spaces here, lots of blood in them. It's lined by these cells. They're cuboidal. And then I think there's some rounder cells in the middle of it. And so I think we have a lining cells and we have some round cells, and it's a well demarcated lesion. So this to me, I think this looks like a sclerosing pneumocytoma. And so it's tough frozen.
I always forget it. It should have 4 patterns, shouldn't it? The hemorrhagic one, the sclerosing, the solid, and there is another part. I always forget.
Yeah.
I don't know.
So
Maybe the
this looks like
macrophage.
Papillary, something.
Yeah.
Maybe papillary. Yeah.
So it looks like a classic sclerosing pneumocytoma. I think hopefully we'd be brave enough to call that on frozen and without many hedge words. But probably, I think this is as good as it gets on for this entity. And I think recognizing this could be a big save, right? Because I think you could call this an adenocarcinoma, or you could see how someone might call that with these spaces here, especially if it had areas that were more papillary, right? And then they might get more resection than they actually need, right?
So by big save, you mean you saved her a little bit of lung tissue, right? Right?
Yeah, because it's a wedge versus a lobe, right?
Right.
And there's more complications associated with a lobe, right, than a wedge, right? Sometimes,
Sure. But you know that we are very hard on ourselves as pathologists when we go from wedge to lobe, right? We say, oh my God, it's a false positive, we did that. But surgeons do lobectomies for benign things all the time. They'll take out a hematoma, a necrotizing granuloma, and abscess, and they're not that hard on themselves. They go, well, this was a growing nodule, and there was no other way to take it out. So I think we have to cut ourselves a little bit of slack. Although I totally agree with you. And if you can make this diagnosis on frozen, which you should in this case, I think it does save the patient something. So I'm not arguing with you, man. I'm just saying that a lobectomy is not as big of a disaster as we commonly think of it.
So we have a pancarotid
here. When we fail, we feel really bad. When I failed, I feel really bad. And what you say is right. They prefer that you make the mistake and they remove, because they already calculated the patient for a lobectomy, so the patient can stand a lobectomy. But if you make the mistake the opposite, you say it's not, and they have to go back and do the lobectomy in something that it's already removed, is worse. It's worse to make that mistake. But everybody makes mistakes.
Yeah, for me on frozen sections, like you mentioned, like adenocarcinoma is the big one, which I want to exclude. But sometimes when I look at those bland cells, so similar to each other, I also think of carcinoid tumor a little bit. And then when I look at the vascular spaces, I remember the old name of the sclerosing pneumocytoma, that is sclerosing hemangioma. And then means we have a rapid stain called AKT1. No, I'm just kidding. There is no rapid stain.
Yeah, but one
AK
thing, one thing Irene said. So, Irene, can you take it to super low mag like you had in the beginning? Super low mag. Yeah. You said a woman, never smoker. And then at low mag, you see this very well circumscribed nodule with hemosiderin on the periphery, like in the normal lung next to it. Yeah. So you're almost at sclerosing pneumocytoma already at low, with that much.
Yeah, no, I agree.
Yeah.
Yeah, but there were some
the-
lymphoid cells at the periphery. So
Sorry?
only one, there were some lymphocytes at the periphery of this well circumscribed lesion. Again, if you're thinking this well circumscribed lymphoid kind of lesion, the other condition which comes to my mind is angiomatoid fibrous histiocytoma.
Yeah.
Again, the morphology is completely different,
Right.
where there's like epitheliate kind of cells and everything. Because I had sometime I had this case of angiomatoid fibrous histiocytoma, and I was thinking all kinds of stuff, right, from sclerosing pneumocytoma to carcinoid tumor to the adenocarcinoma, all kinds of vascular stuff, melanomas. I was thinking everything on the plate. And then the
Maybe.
surgeon comes to me, that patient already has a history of some tumor, which I don't know how to pronounce the name of the tumor. And then I looked at the history, and then it was AFH, angiomatoid fibrous histiocytoma. And then I said, oh, that's the same tumor. We are in the same direction.
Yes.
So again, something I remember with my past experience.
Yeah, but remember that AFH in angiomatoid fibrous histiocytoma is much more of a zebra than even sclerosing pneumocytoma, right? In the
Yes.
lung, that would be a zebra among the zebras.
Yes. 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 Absolutely.
You have to know this diagnosis to say that in a frozen. It's impossible to.
Right.
Yeah, it is. It is. The frozen section is always tough for this.
One of my colleagues always says the eyes cannot see what the mind does not know.
Yep.
And so if you don't know this exists, you won't see it.
Yes, correct.
So this
But
is
the
a TTF1.
but the glasses can see.
The TTF1 is positive in surface cells and round cells, as we expected.
Yeah.
And cytokeratin is positive. Here is
Yeah,
just in the round cells.
also
And
as
the epithelial cells.
not the best area, maybe.
Can I take a second to
Here-
explain this, Irene? Because there will be students watching this video. Can I take a second to explain it?
Absolutely.
Okay, so what Irene is showing now is what I think is really the main neoplastic cell is the round cells in the middle, those that are negative for the keratin. So those are the so-called stromal cells in a sclerosing pneumocytoma. And those are very interestingly positive for TTF1, but negative for pancytokeratin, which does not correspond to any normal cell in the lung. So think of that again. It's positive for TTF1, but negative for pancytokeratin. She's going to show it side by side, I think. So this is a very interesting cell that drives this sclerosing pneumocytoma. And it's located in the interstitium and it's called the stromal cell. Now, the other kind of cell that's in this tumor is the so-called surface cell, which is, so Irene will point to it on both stains. So it's positive both for pancytokeratin on the left and for TTF1 on the right. And these are bigger cells, so they look more atypical. And they are thought to be part of the tumor, but that's debatable. But anyway, that is called the surface cell. Now, the surface cell has a morphology and immunophenotype identical to that of a type 2 pneumocyte of the lung. It's TTF and keratin positive, it's hobnail shape looking, and it's plump and everything. So it looks and stains like a type 2 pneumocyte. But the stromal cell, the neoplastic cell, is a very weird kind of cell that is diagnostic of a sclerosing pneumocytoma. Nothing else has this immunophenotype. Do you guys know of anything else that does this? Keratin negative, TTF positive?
The idea is it's like some primitive mesenchymal thing or primitive remnant or something that it's recapitulating. Is that kind of the idea?
Yeah, that's the idea. But what primitive what? There's no such thing in the lung. I mean, you can make up anything you want, but and they've made up that concept in the WHO of a primitive whatever the other, but there is no such primitive thing in a normal lung.
It'd be called the
actually,
Sanjay cell.
what they had to do, so how the history went is that this thing started off as sclerosing hemangioma, right? Like one of you mentioned from Libo. So people were very happy when they could disprove that, they could prove that that was not correct. Because clearly this is not endothelial, right? But so when immunohistochemistry came along, they could show that it's not endothelial, but they couldn't show what it really is because it doesn't make any sense. It's not keratin positive. So they had to make up something, and this is what they made up. Primitive mesenchymal or epithelial, whatever. It makes no sense. We still don't know what this thing arises from, despite immunohistochemistry and molecular and all that.
What does the
Sclerosing
69
hemangioma.
version say?
Yes,
Hemangioma.
that's how much it is. Like you can see a few lines there. It's exactly 6 lines mentioned in this 1967 WHO edition.
Wow.
It mentions the sclerosing hemangiomas, and they do mention hemocytin-laden macrophages accumulate in the hyaline stroma, and they can be confused for papillary carcinomas or hematomas.
Yeah.
Yeah,
Okay.
again, I find it difficult. Say, for example, the frozen section, we have this kind of morphology. You're looking at this lesion, and then suddenly the surgeon says there are multiple lesions in different parts of the lung, and then you're wondering about. So by this time, you're thinking sclerosing pneumocytoma, but when it says multiple lesions, I know sclerosing pneumocytomas can have multiple lesions, rarely part of the syndrome, but you obviously think of a metastatic kind of process. So just wanted to bring that up, unlikely scenario, but it can happen because I had some cases which had multiple sclerosing pneumocytomas.
Yeah. Oh, I love this three in the same. Oh,
Beautiful,
beautiful! This is so
beautiful,
beautiful for teaching.
beautiful.
What
Wow.
digital allows you to do?
They all move at the same time. That's incredible.
Incredible. Like Irina, I feel like I should stand up and do a standing ovation. This is so beautiful.
Yeah, thank you.
It's a
I can
textbook
put more
quality image
even.
right there.
I don't have more stains, but I can put, I think, 9 or 6 at the same time.
Beautiful. Yeah. It just is,
9.
because you can see exactly the same cells in every field. It's really nice.
Yeah.
I think it's the
But I
power of
still
digital
don't know
pathology, right?
where this, but I still don't know where these cells came from.
That's right.
You said power of dreams or power of technology, Matt?
Well, this is my dream. I'd love to have this, but it's so I guess both.
Okay,
I might have to go to
nice.
Spain to get some digital pathology.
Yes, 10 years and then a little exam to become a
Very
citizen.
nice. Very nice.
Then we move to the last case, I guess was.
My turn. We are looking at a needle core biopsy.
Sorry, we are not doing. No, I haven't changed my. I don't know what happened. I haven't changed. Oh, here. Sorry, I think I have some history for you this time. No, sorry. Wow, I don't have history for you in any case.
Yeah, we don't need any history. We are pretty good with diagnosing without histories because that's what most of the times we have no histories. So
We are comfortable.
we have a malignant tumor here because there's a lot of cells. The cells are epithelioid. They're plumpy. They've got abundance of cytoplasm. There's a lot of necrosis also interspersed between these viable cells. Again, because of the pleomorphic nature, again, my differential diagnosis includes a it has got this prominent nucleoli, multiple nucleoli, mitosis, pleomorphic nuclei. I'm thinking primary lung carcinomas with pleomorphic features, but some areas it has this monotonous appearance. So I'm also thinking mesotheliomas, but I know that mesotheliomas will not be this pleomorphic, especially the epithelioid mesotheliomas. But also I'm also thinking melanomas in the differential diagnosis. But she's showing me some pink stuff here. The squamous differentiation, keratinization, that's dyskeratotic cells. So I'm thinking squamous cell carcinoma with pleomorphic features. Also in the differential diagnosis. Again, those are my thoughts, but clear cut, it's a non-small cell, but I would do a P40 to see if it stains for squamous cell carcinoma. In addition to that, I would also get a keratin in this case. Oh, this is
P40.
P40 is completely negative. That's good. So we have excluded.
There are
There's
some
some
cells, but I tell
scattered.
the residents that
Anti-enough.
we should say negative in this case.
Yeah. So did we do a keratin?
There are some cells. There are a lot.
Yeah, I don't know if you have to say negative, Irene,
No,
but
I
but even
was.
if you say focally positive, this is not enough for squamous. It's not
Correct.
enough for a
That's
squamous.
the thing. I thought was another case with less, but this has a lot. This is TTF1. Sorry, this is TTF1. But what I tell them is that if you have very few with TTF1 very positive, TTF1 is the boss. But in this case, maybe there are. It's not a squamous cell carcinoma. This is for sure with this
Right.
little. But I would say P40 focally positive.
Yeah.
So I showed you the P40, and I showed you also the TTF1.
TTF1 is negative as well. Yeah.
Yes.
What about keratin?
I have CK7.
Yeah, keratin
Oh,
positive strongly. So it's not a melanoma because melanomas are keratin negative. So it's a carcinoma. So at least at this point of time, non-small cell carcinoma. And again, I still want to keep mesothelioma because I exactly don't know where this biopsy is coming from. If it is lower lobe of the lung closer to the pleura, so we don't know that history. So I still want to keep the differential primary lung non-small cell carcinoma NOS because both TTF1 and P40 are negative, and then mesothelioma. Again, I'm going more towards the lung because I'm expecting this not from pleura or anything closer to the pleura.
I imagine the history was clear because I didn't do anything to roll out mesothelioma.
Yeah.
And
Yeah.
I call it non-small cell lung cancer with pleomorphic cells,
Yeah.
possible pleomorphic carcinoma, because we are not allowed to say pleomorphic carcinoma in a biopsy. And I don't know if you want to add something, but I have the resection.
Yeah.
You have the resection?
Wait,
Yes.
wait. Before the resection, let's hear. Matt, how would you bottom line this on the core needle?
I would do non-small cell lung carcinoma, not otherwise specified.
Yeah, I would also do NOS, and I would leave it like that.
Would you
Non-small
mention
cell.
pleomorphic features?
I wouldn't. So this is a good time to discuss this. That the pleomorphic, same as sarcomatoid, right, Raghav? I mean, it's
Yes.
very much in the eye of the beholder. What
Yep.
what is too pleomorphic to be just non-small cell NOS? There's no clear-cut line there, and my pleomorphic might not be yours, and so forth. I don't think it really makes any difference. The same thing is for sarcomatoid. My spindle cell might not be your spindle cell. It might not be enough for you to call. And so I don't worry about that too much. As long as it's non-small cell, I'm fine with whatever you want to call it.
Yeah, I agree. I was noticing the pleomorphic features just for my sake that this tumor has got a severe cytologic atypia, kind of a upper end of the spectrum in terms of atypia. Because again, there will be a thin line when you cross that line and become pleomorphic or pleomorphic features. So I do think that I agree with you that I would just call non-small cell carcinoma NOS because TTF1 and P40 we did it. Both are negative, and that's what we do as well.
That's great.
I think you're right. It doesn't change anything. If you say pleomorphic or not, if it's resectable, they are going to resect it, and if it's not, we are going to do NGS on that. So it doesn't add much to the diagnosis. Here is the resection of that case, and it's really in the resection we should at least, I don't know for what, but we should classify properly the things, and I think this is a pleomorphic. I know there must be there must be variation between people in what is pleomorphic and not, but I think this is ugly.
Oh, I see. So you called it pleomorphic carcinoma?
Yes, I think there was a part of adenocarcinoma in the resection. Finding it, there was a small component. Maybe it's not in this slide.
There was?
There was
Oh,
a small component of adenocarcinoma in
hmm.
the resection. I
Well,
think.
Then there's many ways to do it, right? Well, Irene, so for example, if there is a clear-cut component of adenocarcinoma, you could argue that the other part is just the solid variant of that and then call the whole thing adenocarcinoma. That's another way to look at it.
Yes.
If there was no
So you,
adenocarcinoma component, would anyone call this large cell undifferentiated?
Yeah, that's
Assuming
what
it was
I
all
would do.
TTF and P40 negative.
Correct, yeah. Although I find nowadays true large cell is very, very uncommon, and I always doubt myself that something is wrong when I'm calling something large cell carcinoma. But
so
yeah,
you
you will
won't call
occasionally even.
you won't call the resection pleomorphic neither?
No,
No.
I don't think so. Show me the worst part, Irene, the worst ones. Yeah, like for this, I don't know.
What? It's totally
I think
in
I
the
would
eye
call
of the
this.
beholder.
Totally in the eye of the beholder. Yeah, but if you wanted to call it pleomorphic, I would have no trouble with that because obviously it is pleomorphic, right? It's just not. Is it enough to call it, put it in that same
Yes.
group as sarcomatoid carcinomas? Yeah, I understand. Yeah, it is bad. It's very bad looking. It's very horrible looking, Irene.
Yeah, I think the part of the problem I feel is the WHO says at least 10% of whatever spindle cells or giant cells in the definition of pleomorphic carcinoma, because it's unlikely that we get the entire tumor filled with spindle cells or giant cells. It's these kind of cases where we have a poorly differentiated component with some cells which are large and they're irregular, scary looking. And again, would you interpret them as giant cells or would you interpret them as something falling in the pleomorphic? Of course, if it's described as a pleomorphic appearance, but is that enough to put them into that pleomorphic carcinoma category? Again, sometimes I struggle with that, but for me, again, I would say that for me, this again would be a poorly differentiated adenocarcinoma, like a solid variant kind of a thing. And I would leave it for molecular testing for finding the targetable mutation. And again, the pleomorphism is not sufficient for me to fall into the category of spindle cells or giant cells category for me to call pleomorphic carcinoma. Uh, but again, obviously, I did not look at the entire slide to make that call. But Matt was also saying large cell carcinoma is another differential diagnosis, which I've also moved away from making that because obviously there should be something else other than large cell carcinoma. But I do have reservation with the diagnosis of pleomorphic carcinoma. But at the end, I think it would not matter for the treatment purposes.
It matters zero. There's zero
Yeah.
difference. As long as you don't call this squamous cell carcinoma, everything goes into one box, in the same
Yeah.
box. So
Yeah.
it makes no
Yeah.
difference.
Great case.
Yeah, great discussion to
So
have actually. The pleomorphic
I
large, that discussion is a good one to have.
I finished my tumor cases. I think we can begin the non-tumoral in another session.
That sounds great. Well, it was a great session. Thanks everyone for joining, and stay tuned for our next session that will tackle some ILD cases.